Hey guys, welcome back to Job Study Smart Fun, and for today our topic is going to be radiology and part 1. In part 1 and part 2 we're going to talk about the respiratory system. So without further ado, let's start. So guys, whenever we start about the chest x-ray especially, I have made already a 10 minutes video in which you can get to know all the basic crisp concepts about the x-ray. Please do watch that video first and then come to this video. Okay, before you start with watching any x-ray specifically or CT scan, you need to know what is black or what is white. Guys, air which we are breathing right now on the x-ray is always going to be black in color. Okay, anything other than air is going to be white. For example, pleural effusion, for example, any consolidification, any calcification, the bones which you see over here, everything is white. Other than that, everything which is black in color is basically your air. So remember, black is air, and other than that, it is white. Okay. Now guys, whenever we talk about an X-ray, always remember in X-ray, what is the trajectory? As in the first video we have discussed, you have to remember two things, right? One is going to be RIPE, and the other one is going to be A, B, C, D, right? And E. So where R stands for rotation, you will check whether it is in line. I stands for inspiration, whether it is adequate inspiration. P is going to be the trajectory. Now trajectory can be of two ways. One is going to be anterior posterior and one is going to be PA, which is posterior anterior. We usually prefer the PA view in general conditions. Now why do we check for the PA view is because if you do an AP view, you will get something which is known as a false cardiomegaly. You will have a false cardiomegaly. And what is cardiomegaly, guys? If on the X-ray you find the cardiothoracic ratio more than 0.5, that is known as cardiomegaly. Remember guys, whenever you do a PA view, it is going to be in erect and in full inspiration. Now why in full inspiration? Two reasons. One, so that we can check all the vasculature, visualization will be better. And second condition is so that if you are in expiration, as you know, if it is or if your air is expired, there will be no air in the lungs, due to which the lungs will not appear black in color. Now, in one condition which is pneumothorax, we don't do it at the time of inspiration. Why? See guys, as I already explained you, we'll just explain it here in the written form. In the time of inspiration, there is air inside, due to which it is going to be black in color. While at time of expiration, air is released outside, due to which it is going to be white in color. But pneumothorax is a condition in which there is air but not within the lungs, it is outside, due to which the thorax which is there is going to be black even at time of inspiration as well as at time of expiration. All right, so remember, chest x-ray we generally do it in PA view. AP view is only done in case of trauma. In case of trauma you do AP view. Okay, next guys, let's talk about HRCT, which is high resolution computed tomography. Why do we do this? We do this HRCT to check about the lung architecture. What is this used for? There are two conditions in which HRCT is going to be the investigation of choice, guys. One is going to be bronchiectasis, which is permanent dilatation. We talked about this already. Another condition which is going to be there, it is going to be interstitial lung disease, ILD, which is interstitial lung disease, which is basically fibrosis. So in that conditions, you're basically going to do HRCT. Next guys, we'll be talking about cancers. Now especially whenever in any part of the body, whenever you check about a cancer, you're going to do a biopsy. But before biopsy, we are going to take an investigation. Ideally, in all lung cancer type patients, we are going to do CECT, contrast enhanced CT scan. But in one type of tumor, which is known as the Pancoast tumor, what happens in Pancoast tumor is, guys, it is a tumor in the apical part of the lungs, Now, because it is involved here, you guys know with like information of anatomy, there are brachial plexus over here. Now, because brachial plexus are there, the nerves are involved. Two things will happen. One thing is that the nerve is going to get impinged, because of which you'll have a unilateral pain. Second thing which you need to know is, since there is the brachial plexus are there, this tumor usually compresses the T1, and you know that the T1 is responsible for carrying the sympathetic supply. Now because of T1 compression, there develops a syndrome which is known as Horner syndrome. Now Horner syndrome, they have a specific characteristic. You can remember that characteristic with the help of the mnemonic horny pamela. That's how I remembered it. So for Horner syndrome, which is seen in Pancoast, what will be the pamela which will be there? One is going to be ptosis. A stands for anhydrosis. M stands for meiosis. E stands for enophthalmos. Okay, and LA stands for loss of cerebrospinal reflex. Okay, so remember guys, whenever you see the condition of Pancoast tumor, what you have to remember, it is going to be an apical tumor. Now because it is going to be an apical tumor of the lungs, there will be compression of the nerves, there will be compression of the brachial plexus. Because compression is there, one will be unilateral pain. Second condition is that because of the compression on the T1 sympathetic supply, you are going to develop a syndrome which is known as Horner syndrome. And Horner syndrome has specific characters which will be remembered with the help of horny pamela, which is P is for ptosis, anhidrosis, meiosis, enophthalmos, and loss of cerebrospinal reflex. Okay, remember guys, that is going to be in case of the initial investigation. For all other conditions of lung cancer, it is going to be CECT, but in Pancoast tumor, because there is involvement of nerves, your investigation of choice is going to be MRI. Okay, but for the final diagnosis, obviously you have to do a CT guided biopsy. Okay, next guys, let us find some conditions in your with respect to the thoracic cavity in which you will have whiteout and which you will have blackout. So let's talk about whiteout. Now as I told you earlier, what is black? Wherever there is air, it is going to be black. But if there is no air, for what are the conditions? One, what if there is too much density? If there is too much density guys, that will be considered as consolidations, and consolidations will be white in color. Next, when there is no air, see, if there is so much air, it is going to be black. If there is no air or very less air, it is going to be white, seen in conditions of collapse. And also whenever fluid is going to be there, again it is going to be white in color. Now how do you distinguish amongst three of them? All are white. So remember guys, we will check it with the help of tracheal deviation. Remember A, B, C, D, A is the airway. We check the trachea whether it is in the midline or in the deviated or not. So in density with respect to consolidations guys, there is usually no or very little tracheal deviation. With respect to collapse, it is going to be ipsilateral, which means the same side tracheal deviation. With respect to pleural effusion, the deviation is going to be contralateral tracheal deviation. So basically, if a patient had pleural effusion on the right side, the trachea is going to be like deviated to the left side. Okay? For examples over here, guys, this is a consolidation. You can clearly see in consolidation, usually there is little to no tracheal deviation. Pleural effusion over here, you can see that it is deviating to the contralateral side. While if you will see with respect to collapse, trachea over here the collapse is occurring, and over here you see the deviation is towards the same side. Okay. Next guys, let's talk about conditions where you will see complete black, means air is there throughout, even at inspiration and expiration. One condition that we already discussed guys, pneumothorax. COPD, especially with respect to the history of smokers, you will have such conditions. Why? Because of hyperinflation, and there will be very difficulty of releasing out the air. So that's why in emphysema, remember guys, we talked about this, patient will be having purse string type air removal, pink puffers which will be there, right? Other condition guys can be a unilateral black lung. Now why unilateral black lung? Just imagine if this is going to be your sides of your lungs, and if there is any foreign body obstruction over here, the air which was inhaled at the time of inspiration cannot go out, due to which you will see there will be black lung over there. So what conditions guys? Pneumothorax, COPD, and then a foreign body obstruction. Then we'll talk about where do you see black lungs, which we will talk more in detail, which will be with examples will be there. First of all, it is pneumothorax, which we already discussed. COPD also, that is all related to increase in air. Whenever there is decrease in density. Now, for example, I'll show you this condition. Over here, you guys can see there is the right breast margin, but there is no breast margin in the left side of the X-ray, because the patient had a history of maybe she had breast cancer, and due to which she did a mastectomy. And over here you can see, even though here you can see black, but it's completely in a lesser shade. Why? Because they have the margin of the breast over here, tissue is there, but in this condition there is no like a breast, and here the patient had a left sided mastectomy, due to which it is more darker in condition. Pneumothorax. History of pneumothorax will be there, maybe it can be a tension or a spontaneous one, but two classical features which you have to remember is there is no vascular markings, okay, and there will be tracheal deviation to the contralateral side. Same like in pleural effusion. Even in pleural effusion, tracheal deviation is going to be in the contralateral side. The difference between both is over there pleural effusion is going to be white in color, over here in pneumothorax is going to be black in color, and classically in pneumothorax there is no vascular marking at the affected side. Okay, another condition is going to be COPD. Now how do I know this is COPD guys? Is first of all, you see there's a tubular heart. Along with that, you can see the diaphragm. with respect to normal other conditions, you see there is so much flattening of the diaphragm, and there will be hyperventilation in case of hyperinflation in case of COPD. Then another will be condition which will be seen in pulmonary embolism. Also, you will see black. Why? Because of the emboli. It can form two conditions. One, we will talk about it in the next video, which will be Hampton hump in case of massive pulmonary embolism. Hampton hump, and you will see Palla sign will be there. Okay. So this is all about blackout in hemithorax. Next, guys, let's talk about the details which you need to know in a specific condition. A condition which is very important with respect to the examination is going to be pneumothorax. In pneumothorax, as I told you, there are two characteristic features. One is going to be absent vascular marking and tracheal deviation to the contralateral side. Contralateral side deviation in pneumothorax and afferent vascular marking. Okay, over here also you can see this is the full lung structure over here. Over here there is a collapsed lung, and over here there is air. So this is also pneumothorax. This is basically an like a CT scan. How do I know it is CT scan? In X-ray and CT scan, the bones are going to be white in color. Okay, guys. In this condition, now if you have a patient who is in pneumothorax and he can't basically stand up, so then basically you did an X-ray on the supine position. So in a supine position, remember, okay, it's going to be in a supine position. You're going to have this sulcus. This is known as the deep sulcus sign in pneumothorax. Okay, deep sulcus sign in pneumothorax. Now you want to confirm your diagnosis more, then you also did an ultrasound. See, guys, when you do an ultrasound of the thorax, okay, usually you'll have this seashore sign. What is the seashore sign is? Just imagine like this. It is going to be a sky, then will be your water, and then will be sand. So you can see it is like, it's an imaginative way to understand this. It is going to be on the top sky, then water, and then sand. This is considered in normal conditions. But what happens in pneumothorax is you will have a thing which is known as barcode sign or stratosphere sign. Now in barcode sign or stratosphere sign, you can see there is no such differentiation. Over here you could see some darker line was sky, then it was little lighter is going to be your water, and then granulations which were looking like a sand, right? Over here you can see everything is same, just the light is different. So this is like basically like a barcode or a stratosphere sign which is seen in pneumothorax. Then another one, if you see, it looks like a pointing sign. This is known as lung pointing sign. Another sign which is seen in pneumothorax. Not only just another sign, guys, but if they ask you what is the most specific sign in pneumothorax, you have to say lung point sign. Okay, lung pointing sign will be there. Now we have already discussed about tension pneumothorax and spontaneous pneumothorax, but as we are going to revise everything, as we are trying to integrate, so let's do it like that. So before I say, I hope you're answering it already. What can be the causes of tension pneumothorax, guys? It can be gunshot, stab wound injury. Vitals are going to be unstable. What are the causes of spontaneous, guys? Just now we discussed about COPD, smoker. Correct? Then if a patient has staphylococcus and aureus type infection, and he'll develop something which is known as pneumatocele. Or if you'll have rubber band syndrome, which is Ehlers-Danlos. Or you can have Marfan's. So these are the causes of spontaneous. What would be the management, guys? The first thing what you have to do is, if it is an adult or if it is a child, okay? In adult is going to be 5th intercostal space mid-axillary line, or 2nd intercostal space mid-clavicular line in child. What? You're going to do needle decompression. But mainly at the end, what you have to do is ICD drainage. Now, where you do ICD? Usually, guys, you will do it in the triangle of safety. What is the triangle of safety, guys? It will be the latissimus dorsi, pectoralis major, and 5th intercostal, or if you say 5th rib will be there, right? So this is your triangle of safety. Okay, 5th rib. So this is all about your pneumothorax. Next, guys, let's talk about pneumomediastinum. So please don't think that both are the same thing. Pneumothorax and pneumomediastinum, they're completely different. Pneumomediastinum, guys, is usually also seen in a condition which is Boerhaave syndrome. Now, how do you have Boerhaave syndrome? Basically, it's also known as spontaneous esophageal perforation. Now, there is a triad, guys, in Boerhaave syndrome. Now, what is this triad name, and what are the 3 characteristic features which are seen in Boerhaave syndrome? Please comment below. Again, if I will answer it for you guys, it will be passive. If you search for it, if you know it like this, you'll retain it for longer. Okay. So, what is the triad, and what are the features of the triad of Boerhaave syndrome? Please comment below. Guys, whenever you talk about the classic feature with respect to pneumomediastinum, the most sensitive diagnostic method is going to be CT scan. Okay. Next thing what you guys need to know is, what are the features you see in pneumomediastinum. So again, this is going to be a CT scan. Over here clearly you can see air over here along the arch of the aorta. So this is air over here. So this is pneumomediastinum. Then guys, you can see usually below the heart, and you see the over here, if the heart is there and this is the diaphragm, usually you don't see a line such like that. Over here you see this line, there is a gap. This guys is known as continuous diaphragm sign, which is seen in pneumomediastinum, continuous diaphragm sign. Okay. Another thing, along the heart, if you see this V is there. Okay, if you see this, there is a V over here. This is also known as Nelcros V sign, seen in pneumomediastinum. Over here, if you see, because of the thymus and because of the pressure and the deviation over here, you will have something like this, a consolidation type thing. This is known as Spinnaker's sail sign. It can be seen bilateral as well, but what I'm trying to show is in this condition over here. See, you can see here, this is also another condition which is seen in pneumomediastinum, which is known as Spinnaker's sail sign. Okay, and last here, because of subcutaneous emphysema and another all stuff which is related to the bore have, as well as pneumomediastinum, you will have something which is known as the ginkgo sign, which is like a leaflet. Like, see, you can see the multiple striations over here. Over here also you can see multiple striations. This is known as ginkgo leaf sign. Ginkgo leaf sign. Okay. This is ginkgo leaf sign. Okay, so these are all the things which you have to remember in pneumomediastinum. One is going to be continuous diaphragm sign, then is going to be Nelcros V sign, Spinnaker's sail sign, and ginkgo leaf sign. Ginkgo. Okay, ginkgo leaf sign. Next, guys, let's talk about pleural effusion. Now, in pleural effusion, if they ask you what is the most sensitive investigation, that is going to be ultrasound. Why? Because basically there is fluid, so ultrasound is meant for that purpose. But if they will ask you what is the best X-ray mode, in which position will you keep? Lateral decubitus. Okay, but which side? Ipsilateral, which means on the same side, or contralateral? Guys, the answer is going to be ipsilateral. Why? Because if you do it in the ipsilateral side of the pleural effusion, where it is going, okay, over here you can see the fluid gets collected with the help of gravity, so you can have a differentiation. Okay, so remember, the most sensitive investigation is going to be ultrasound. While if you talk about which X-ray is best, that is going to be ipsilateral lateral decubitus position. Okay. What are the sign, guys? As we discussed earlier also, the classic sign which you see, this is going to be your costophrenic border is usually sharp, right? But in case of pleural effusion, there will be blunting. And guys, this blunting is the first sign of pleural effusion or hemothorax. Okay. Along with this, guys, over here, as I said, you air wherever is there, that is going to be black. Rest all will be now. You have to think about consolidation, or you can think about collapse, or you can think about your pleural effusion. Now, how I know this is pleural effusion is because you see there is a curve over here. This curve is known as, guys, Ellis curve. Okay, remember the lateral part is going to be much more longer, and this is seen in pleural effusion. All right. Then another sign which is there, if there is in the pleural effusion, obviously if there is infection or something, you will have something which is known as the split pleura sign. Now, what is split pleura sign is, guys, you can see over here there is a clear demarcation over here. This line which is there, guys, this is known as the split pleura sign. Okay. Or over here also you can see with differentiation. Remember, always with respect to CT and X-ray, whatever you're seeing is your left is actually the right side. So over here you can see, because the patient is right now in a supine position, because of gravity, fluid falls below, and due to which you can see fluid collection over here. Okay. So remember, three things which are there in case of pleural effusion. Earliest sign is going to be blunting of the CP angle. Then it's going to be Ellis curve characteristically, and that is also going to be in the lateral side. And along with that, infection will be there, empyema might be there. So then you have split pleura sign. Okay. Now, if you talk about the differentiation, so just to overall to sum up, remember in pleural effusion, the deviation is going to be where, guys? It is going to be in the contralateral side. Okay, there is deviation in the contralateral side, and also along with this, you'll have the Ellis curve, right? there is a condition which is hydropneumothorax. So by decode the meaning, hydro water, pneumo air, thorax. So then there is a mix of both water and air in the thorax. Now because of gravity, water is going to be down, so that is why it is going to be white in color, and air is going to be up, that is why it is going to be black in color. Now if you see the differentiating feature between pleural effusion and hydropneumothorax is, as I said you, in Ellis curve there is a curve, while in hydropneumothorax you have a straight line over here. So that is a differentiating feature. And over here in pneumothorax, as I said you, absolute vascular marking and contralateral deviation of the trachea. Okay. Then guys, let us talk about what are the difference between parenchymal issues and extra parenchymal. How do you differentiate it? You do it with the help of a sign which is known as the air bronchogram sign. Now air bronchogram sign is nothing but this. If you can see, there are multiple dots over here, right? This is basically because during this involvement of, like example in pneumonia, consolidation, something like this, the bronchus is not getting involved, due to which there is air. And as I told you, air is going to be black in color. So whatever parenchymal issues are there, any parenchymal issues there, you are going to find this feature which is your air bronchogram sign. Okay. So over here also you can see, like it's like how roots are coming out. So this is also the air bronchogram sign. Now guys, let us talk about where do you see these conditions. Any consolidations which will be there. As we told about consolidations, collapse and pleural effusion is going to be white. So that is why, remember, but in case of consolidations, which is a parenchymal issue, pleural effusion is what? Pleura. It is not in the lung involvement. So any condition which is involving the lung architecture is going to have consolidations. So basically if you will see pneumonia, any cancer such as bronchoalveolar cancer, pulmonary edema, pulmonary hemorrhage, and hyaline membrane disease, which was, remember we studied in case of RDS, which will be there, right? So whiteout lungs will be there. Wherever you will have no involvement of the any extra parenchymal issue like pleural effusion, you will not have this air bronchogram sign. So another differentiating feature you got, one, in pleural effusion you will have the Ellis curve. You will not see that in consolidations. In consolidations or any involvement of the parenchymal lung structure, you will have the air bronchogram sign, which is basically in a white part you will have black dots. Okay. So over here, this is, do you see any black dots? No. So what is this? This is a pleural effusion. To confirm it, you see the contralateral deviation will be there. In case of consolidations, there is little or no deviation, right? Next guys, let's talk about the difference between consolidation and collapse. Before which you need to know, which we already discussed, the lobes. So remember guys, in the right lung, you are having 3 lobes, and these 3 lobes are divided how? With the help of a horizontal fissure and with the help of a oblique fissure. While in left side only it has 2, upper and lower lobe, and this upper and lower lobe are divided with the help of, this is over here, upper and lower lobe. So the upper and lower lobe are divided with the help of an oblique fissure. Okay, so remember 3 lobes, 2 fissures, whereas in the left side you'll have 2 lobes and 1 fissure. So how do you differentiate between now a consolidation and a collapse? One way is, see, in a consolidation, tracheal deviation is almost not there. While in collapse, the tracheal deviation, because of the volume effect, is going to come on the ipsilateral side. One thing. Second thing is, guys, in case of consolidation, example, I know this is going to be an upper lobe consolidation. How? I will just draw the fissures. Imagine a fissure. So first, always I said you, horizontal is going to be there, then it's going to be oblique. So if this is your horizontal and oblique, you know this is the upper side, this is the middle, and this is going to be the lower. So I know the consolidation is going to be in the upper lobe. Now, how do I know this is a consolidation, guys? Is that this fissure which I have drawn now, it is not pulled towards the lesion. In case of collapse, guys, if you see, the fissure is pulled towards the side of collapse, and there will be tracheal deviation towards the same side. So 2 distinguishing features are there. One is, by the with help of fissure, you can see if there is no displacement of the fissure, you guys can say that this is a consolidation. While if there is any displacement of the fissure and tracheal deviation to the ipsilateral side, then that is a collapse. Repeatedly same image has been coming in the examination, in which patient had a history of TB, they'll give like this, and a patient, when on the time of when you checked on the X-ray, you had a white lesion on the top. Now along with this, you saw that there is a tracheal deviation towards the same side, and you see that there is loss of the fissure margin. The fissures are being deviated upside. So then this is basically a condition of collapse with which previously a patient had TB with. Okay. Now guys, in case of a collapse, specifically a very important sign which is known as the reverse S golden sign, in which a patient usually had maybe a bronchoalveolar cancer over here, and there was a mass, because of the mass there was fissure displacement and thereby developing an upper lobe collapse. This over here, you guys, you can see it looks like a S, but this is looking like an ultra S. So that is why this is known as reverse S sign, which is seen in upper lobe collapse of which condition, guys, with associated with a mass such as bronchogenic cancer. Okay. So thereby, to sum up with respect to what are consolidations, as I said you, in consolidations, first you will see some dots will be there. That is your air bronchogram sign. Any parenchymal issue will be there. You will have the examples of air bronchogram sign, and then it's going to be white. So how do I know it's going to be upper or middle lobe? Just draw the fissures. So first I'll draw the horizontal fissure, and then I'll draw the oblique fissure. So I see there is not much involvement. There is actually some involvement over here, but if you see majorly there is involvement of the upper lobe. Correct. In this condition over here, you can see that, see, now whenever you have to look in this condition is that whenever there is involvement, now especially in the left side we know that there is only one oblique fissure, right? So over here, so I know it is going to be a lower lobe. But if they give you right now this type of image over here and they show this lower portion, again in this lower part of the region, you have to mark this condition as again lower lobe involvement. What you have to mark? You have to mark this condition as a lower lobe involvement. Okay, so over here, remember in the left one you have only two lobes divided with one oblique fissure, and over here in the right side you will be basically dividing it with the help of one. So you will be dividing it two fissures, which is going to be horizontal and oblique, right? So over here also same condition. How do you divide this? Just divide it like this, horizontal and oblique. So now you see that there is involvement of the middle lobe, right? And over here also, as I said you, that this part at the back is going to be your it will be divided basically by the oblique fissure. So then the lower part is always going to be the lower lobe, upper part is going to be the upper lobe, and over here if you see this condition, involvement over here is going to be in the middle side. Okay, so that is all for this video with respect to pneumothorax, with respect to pleural effusion, with respect to consolidations. How do you distinguish between blackout lungs, whiteout lungs, air bronchogram sign, and much more. So see you guys in the next video. Take care.